Good afternoon, everybody. Early on in the year, it's good that we introduce each other. So I'm going to say who I am, but I haven't met you from the view, but call me Dr. James, Dr. Vernace. With the internal medicine program, the TY program, and today's topic is definitely applicable to most of us. We're only 3 weeks into training here, and I'm sure if you had a floor rotation, you can grasp the confusion and the room for improvement for managing inpatient hyperglycemia. Okay, with as simple as where to start with an insulin regimen, how to adjust the insulin, what do you want to hold, what do you want to have, how do steroids play a role into this? So I think if you're an intern, this is good to give you some clarity and also make you more comfortable and make you more confident in rounds and honestly make your workflow easier. Okay, so like I said, I think it's good whenever we're talking about a topic, why is it important? And there's multiple reasons why this topic is important. And I think if you understand why we measure some things and some of the metrics, it will help you be more aware and attentive when you're managing this yourself. After this, we're going to be able to look at a patient and be able to start an insulin regimen, be comfortable with reading a number. It's not just a guessing game. It's not just increase in insulin regimen, just a little bit. If they were a little hyperglycemic, there's a science to it. And I want you all to feel confident about doing this on the floor. And then one major thing we see, of course, in the hospital is steroids and how that impacts the blood sugar. And there is a real science to how to manage with steroids. And it's a huge contributor to falling out of our metrics, but even besides that, harming the patient. And then lastly, I just accumulated some gold nuggets, I guess, some pitfalls, some points to be aware of with hyperglycemia that I kind of accumulated in my own mind over the years. Okay, like I said, the primary goal to understand this topic is to provide the best care for our patients and to practice evidence-based medicine. And when you're looking at hyperglycemia in the hospital, there's many guidelines, many literature, many different associations recommending different ranges. So you can see here the American Diabetic Association, that's the ADA, and the AAC is basically Clinical Endocrinology Association. But they're all ranging from 100 to 140, and even in Europe, 108 to 180, that's a specific range. But really the consensus is 140 to 180. If you're critically ill in the ICU or PCU, you're leaning towards 180. If you're med surg and stable, we're leaning towards 140. But you'll hear a lot on the floor of just keep them between 140 and 180. And then why is this important? They've done plenty of retrospective data and quality improvement data showing increased length of stay for patients that have uncontrolled diabetes, worsening exacerbations of their already chronic conditions, and then increased mortality and morbidity. So this is important for us, right? We want to minimize all these things. This just kind of goes back to the metrics. I mean, the real life clinical hospital practice, everything you're going to do is tied to some metric. Even if you're going into anesthesiology, you're going to have metrics on intubation, extubation times, complications, right? Everything is measured. So that's how a hospital system can look at us and see how we're doing. So you understand some of these numbers, you may be a little bit more aware on the floor. Really, besides the 140 and 180, that's what we want to do for our patients. The hospital keeps track of these numbers. And for me, anytime the blood sugar gets above 300, that's like a red flag in my mind. I really need to focus on that because that's the cutoff for the hospital to realize the major thing for our service and how we practice care for patients. So, and not that you need to memorize this, it's just good to just hear it once. But out of all the patients we see, they want less than 8% of them to have a blood sugar above 300 at any point in the hospital. Okay, so of course we want to do the right thing, 140 to 180, but really think about what am I missing, and I need to really complete this insulin regimen if I'm seeing blood sugar overnight above 300. And then hypoglycemia, I know we all know hypoglycemia is more dangerous than hyperglycemia. And so that target there, the major thing is under 40. Right, but of course, we can already have symptomatic hypoglycemia, even 80, even 90, depending on how much insulin resistance you have and how old you are. All right, and then really they're just looking at basically how many days this patient's in the hospital and how many days did they have a blood sugar above 300. Okay, again, you don't have to memorize this, but if you know the metric, you're a little bit more aware of what you really need to focus on when you're making an assessment and plan. And then one funny thing to note is all the metrics that apply to hyperglycemia is coming from the point of care glucose. So they're not even looking, they're not taking into account the glucose that's on a CMP, the glucose that's on a PNP. All right, so really pay attention to the point of care glucose. That's really showing the hospital how hard you're working and how you're doing managing these patients. And then one thing to know is sometimes we get PKA patients, HHS patients, and they're 600 in the ER, the blood sugar. Your metric, our metric is really calculated once we put the admission orders in. All right, so that's good to know because a lot of them are way off that category. Yeah.
I've got a question. I always was under the impression that the point of care, finger stick, is not as accurate as the, and they're using the non-accurate value.
I think historically that was the case, but I think the devices that we use currently are
really good.
comparable. Yeah.
Okay.
Yeah.
I'm getting over it.
Yeah. One thing that we try not to do is use the patient's cutaneous insulin monitoring because that doesn't line up with the actual part.
Thank you.
Yeah.
Let me ask about the machines for
Yeah.
glucose. So when the nurse or PCA measuring that, it automatically go into a chart or it takes time to upload this?
They have to manually input that. Yeah, we'll talk a little bit about that actually, because that's gonna affect how you make decisions. All right, like I said, you don't need to remember this, but these numbers are good to hear once, right? Now, yeah, this is a good question. Why do we really 99% of the time want to use insulin in the hospital to control blood sugar? Well, why not? Why do we want to use a little bit of oral and diabetic medications that have been around for very long, a little bit of insulin? What do you all think? There's multiple right answers, but why do you think you all stick with insulin in the hospital? Okay, that will play a role. Not the main driving reason. What else do you think?
Easy to adjust in time.
Easy to adjust and titrate. We want full control over the blood sugar in the hospital because we're trying to promote quality care, we're trying to avoid any kind of complications. And so I can't predict if I give someone glimepiride, right? Or another oral diabetic med and say, oh, the blood sugar is only gonna drop by 20. You can't. But with insulin, it is predictable. We know based on their blood sugar, based on their weight, based on their comorbidities, we can do an insulin regimen that's safe and keep the blood sugar at control. So that's why we strictly use insulin in the hospital. And the guidelines have changed over the years. Okay, one thing you need to know, one of the most important things in this lecture, and you'll hear it abbreviated in rounds, know the TDD, the total daily dose. And that's the amount of insulin you can calculate that your patient should need in 24 hours. If you're doing the Glucomander is a very smart software that is giving you what the total daily dose is in 24 hours. But that's a great starting point. You can decide how much insulin does my patient need. I can't see the home records. They're confused. But I need to start a number that's going to be somewhat appropriate. So we'll talk about that in this chart in a second. Some other important things to know is the ADA, the American Diabetic Association, recommends controlling their blood sugar just with insulin, like I said, holding their oral diabetic meds, and you don't, I think you just talked about this the other day with Dr. KB, you don't want to rely on the insulin sliding scale to control their blood sugar. This was done maybe 20 years ago, 10 years ago, but the sliding scale, and I was just talking about this in our team, is only there to help you make the best scheduled insulin regimen. Okay. So think about it like this. Every day you use the sliding scale, you take that number over 24 hours, and we'll show you how to do it, and you put it into your scheduled amount. And if you think about it, every day theoretically, you trim and trim and trim to the point where you're not even using the insulin sliding scale because you calculated the perfect dose. Okay. So in the scenario I mentioned earlier, if you don't even know how much to start on a patient, and you can't get the records, and for whatever reason, you really need to decide as a team how much insulin. This chart right here is giving you a range. So it's either 0.3 all the way to 0.6, sometimes more, units of insulin per kilogram of body weight. And in my mind, I think about like this: frail, underweight, type 1, maybe insulin naive. You're talking about the 0.3 units per kilogram. Okay. Now on the opposite side of the spectrum, high insulin resistance, morbid obesity, and type 2 diabetes, and not insulin naive, I'm thinking at least 0.6 units of insulin per kilogram. That's a good start. That should give you this TDD, the total daily dose. And you're going to take that number, whatever it is, and you're going to have it. 1/2 can go to basal insulin, Lantus, glargine, detamere, and then 1 is going to go to mealtime insulin. Okay. And the reason why I'm just talking about it and not being too specific is it's okay if it's not 50-50. Every patient's a little different. Some patients can't comprehend or do meal time very well at home. So sometimes you may want to just lean more toward basal because it's easier to do. But that's a rule of thumb. Half it meal time, half with basal. And then I think it's either in this slide or another slide. But one of the worst things is you get a patient overnight, and because they're NPO, we've held all their insulin completely. And then we show up in the morning and the blood sugar is 200, 300, 400. The point of that is just because they're NPO and you're on insulin at home does not mean you should be off insulin. You should be on half of your basal if you're NPO, plus the sliding scale. And I have a slide about that.
Yeah. I have another question. When you say obese people, not everybody who's obese is diabetic / insulin resistant. If you take, and I'm going to the extreme, a morbid obese patient, 200 kilograms, insulin naive, you're giving to this patient 6 times 120 units of insulin. I think I would, under no circumstances, ever do that with insulin naive patients. Up to which kilograms would you recommend to use the actual body weight? And at what kilogram do you say, you know what? It's my limits here. If you go to 70 kilograms for everybody, or 100, or 110, 150.
That's your point. The ADA recommends one extra thing here is if you have it, you may not have it, but if you have an A1C, the A1C helps guide this, because if your A1C is 7 and you're morbidly obese, then what Dr. KB is saying, yes, please don't give them 130 units of Lantus twice a day, because their A1C is only set there. It could be normal. They may not be diabetic. So you know, you're taking all this into consideration. That's why, you know, look, there's multiple things in one category. It's not just one thing. All right. Good point. Okay. I don't know if you guys have you use the med history tab or the glucose flow sheet to look at how much units. I'm hearing some head nods. Good. How many units your patient received in 24 hours? Okay. And your senior can easily show you that. But that's what you're calculating. How many units did my patient require in 24 hours in the sliding scale? And you're going to take that and you're going to half it. And you're going to add some to basal, some to mealtime. And you're doing that every day. The reason why I'm bringing that up is, you know, sometimes you'll be in rounds and your plan that day is, I changed the Lantus from 25 to 20. Okay, I'm glad you made a change, but there's a science behind the change. Use the sliding scale, and that will tell you really what you need to do. Okay? Okay, good. I think well, one last note, I put this in here because I've been asked this many times by patients. You know, we may be giving the patient insulin in the hospital. I don't have diabetes. that they would have steroid-induced hyperglycemia, reactive hyperglycemia in the ICU. And so let them know, this is why we're doing the insulin. You don't need insulin on discharge, because I've had many patients refuse the insulin because they're like, no, I'm fine, I'm not diabetic, I'm not buying this insulin discharge. So let them know, this is while you're in the hospital and we're trying to control the reactivity. Okay. This goes back to maybe even undergrad, but definitely med school, with just being aware of the kinds of insulin. You want to know, duration of action, just so you're familiar about what insulin do I want to change. So in the hospital, we use Lantus. Correct me if I'm wrong. I think that's glargine.
Yeah.
So really, it is supposed to act 24 hours. Okay, so it doesn't have this peak. It has a basal kind of long-acting line right here. Okay, and so that's what we're doing as the basal insulin. And then what our sliding scale in the hospital uses is Lispro. And I mean, look how quick this acts. Within minutes, really it's starting to work. So that's what we're using for the sliding scale. We're giving it to them with food, right? And then less often we're using in the hospital here is regular insulin and NPH. They're kind of a hybrid, if you can see the onset of action, right? And the, therapeutic peak. But for instance, you can use them in, let's say, a patient with continuous tube feeds, right? So they're not getting that bolus carb, and you want something that's a little more long acting every 4 to 6 hours. That's an example where you can use, NPH for a patient on continuous tube feed. So there's roles for the other ones, but Lispro you're going to see a lot, glargine you're going to see a lot. Lastly, is this. Kind of in the background, patients that end up having an adverse event to hypoglycemia. I've found a lot of the times they're on the inappropriate sliding scale. So that's not a feeling decision either. Let's just put them on a low sliding scale, let's put them on a medium sliding scale. These numbers are correlating with the total daily dose. That's why it's crucial to know the total daily dose. So if your total daily dose is 40, but they may be very hyperglycemic in that moment, don't react and put them on the high sliding scale. You will cause hypoglycemia. So this correlates with the total daily dose. All right, so calculate it. If your patient is 60 per day, then yeah, I think the medium sliding scale will be appropriate. Okay.
And I have a bit of a pet peeve, but you're correct. I wouldn't call it sliding scale. It is really a correctional scale. This numbers here correcting for what you have calculated wrongly. You have calculated, say, 5 units of Humalog to be given now, but your sugar is really not at a value at the point when the nurse is taking it. So your sugar might be 250, and the nurse will look up. Will say, the doctor ordered 5 units, but the sugar is 250. Therefore, I need to give, in addition, I'm correcting the order, in addition 1 or 2 or 3 more units. But I know they all call it sliding scale, but the proper terminology is correctional scale.
Yeah, philosophically.
Correctional
scale.
Yeah, I said a pet peeve. I apologize in advance.
That's like we're trying to get away from saying hypertensive crisis.
Right.
We're trying to say
Or being on call.
Yeah. Okay. So, this is kind of going back towards why are we using insulin in the hospital and why are we keeping this basal and prandial pattern? Well, that's simple. We're trying to mimic our body. We're trying to mimic the physiological process. This is just a simple chart looking at the plasma insulin for normal person over the day. So you can see, right, we have a basal insulin, 24 hours, no peak, right? Going through here. That's what we're trying to do with the Lantus. And then we're trying to mimic our body. So we do Lispro to give us these peaks here for meals. All right, so that's the goal. Okay, we're trying to do what our body already does well. All right, talked about that. We've talked about the long-acting insulin. One good thing to know is it's very important to look at your fasting morning blood sugar, because the issue is you need to know what insulin to adjust. If you're concerned that you need to increase your patient's regimen because they're 300 blood sugar in the morning, you need to know where's the best bang for my buck. Do I need to increase the prandial insulin or the basal? So if they're fasted and they're hyperglycemic in the morning, you need to address the basal insulin, okay? Because that's a reflection of that last basal insulin dose, all right? Now, if you notice in the afternoon, you're looking at the timestamps, right, for these numbers, and they're 300 after meals, 350 after meals. But the fasting glucose that day was okay, 200s, low 200s, high 100s. Well, then the best bang for your buck is you need to optimize more the meal time. Okay, so talk to your senior about these patterns, but you need to not just looking at the blood sugar number. It's when was that number done? Okay, and then this is kind of what I'm saying here. You can lead to early AM hypoglycemia in an attempt to cover post-meal glucose elevation. So know what you're increasing. Okay. We're going to talk a little bit about prednisone and steroids, because that definitely is going to play a role here. So this is a whole nother population of patients. On everyone's list, I'm sure you have a patient that's receiving steroids for a specific treatment, right? So, and the blood sugar spikes, it's labile, it's hard to control. We're trying to control it, not cause hypoglycemia, trying to minimize sticks, trying to make the patient comfortable, not have the nurse, running around and changing insulin and ordering one-time insulin. So it's good to understand and be proactive and not reactive with this topic, okay? Steroids are extremely potent for hyperglycemia, and they can cause DKA and HHS physiology if you let it get to that point. And like I said, we want to be proactive, not reactive. So we all know it increases blood sugar, and this is just some simple science. You can maybe appreciate why, but it really does cause inhibition of glucose into the cell many ways, even direct effect on the beta cells in the pancreas, and then increases gluconeogenesis as well with the liver, okay? And then just one simple point, there are some small studies looking at patients in the hospital, and 42% of patients, even without diabetes, are in the range of really needing insulin with meals if they're on steroids, all right? So this is an important topic because these can be patients with no diabetes, but we need to be aware and manage them with insulin because they can have the same effect with patients with diabetes and hyperglycemia. Okay. Okay. This is, just like the different kinds of insulin to look at. This is good too, to refresh ourselves. So, mostly in the hospital, what we're using prednisone, right? And then solumedrol, which is methylprednisolone, right? So it's just good to look at how potent are they? What are their anti-inflammatory activity? How long do they act for, right? So we all know that, let's see, dexamethasone is very potent, right? So look at the anti-inflammatory activity, 30, right? And this is all equivalent. So 30 to 4 of prednisone. And that's why we give it to, let's say, acute pharyngitis or other things that really need potent anti-inflammatory effects. And then typically when we're talking about our COPD or other things, we're using prednisone. So lower anti-inflammatory effect, but you can see the potency so that when you're giving dexamethasone, realize that it's not if, it's when they're going to have hyperglycemia, and they may need more than just a sliding scale. Okay, so this is, and you can see, right, the duration of action for dexamethasone is much, much longer compared to the others, right? So it's just good to be aware of. And then, let's see, I've talked about that. I think we all know how to put the diet in the computer. So it's funny, if you read like cardiology journals of patients in the hospital, the ADA, different organizations, a lot of them think every patient in the hospital should in fact be on a carb control diet because of reactive hyperglycemia and keeping the patient stable with this. So I just prefer to keep the patients on carb control as long as they don't complain or refuse it. I think that's probably the best. And then talked about the correctional scale. So they looked at patients just on correctional scale versus a regimen with basal and mealtime. And the incidence of DKA and HH is obviously higher with those. All right. The main thing with steroid-induced hyperglycemia is they really, really affect postprandial glucose. That's the biggest part of how they cause issues. They're really spiking up the blood sugar after that meal, much more than the obvious physiological effect of that happening anyway. So when you're adjusting insulin, you're probably going to be putting more weight on the prandial insulin than the basal insulin, because that is the most potent part for the steroids. They're causing that postprandial glucose elevation, right? So sometimes if I think a patient's going to be on dexamethasone for something serious and they're on an increased dose, like 6 milligrams every 8 hours or 6 hours, and you're already seeing that spike, you're kind of behind the ball already. It's okay to put a low dose 4 or 5 units of Lispro with meals while they're on dexamethasone. That's completely okay. All right. Yes.
Just a quick comment. If the patients are on methylprednisolone, then the physiology of NPH insulin matches that of the methylprednisolone.
Yeah.
Where it lasts 10 to 16 hours, like the methylprednisolone. But if they are on Decadron, for example, for vasogenic edema from a tumor, if they're on Decadron, then the basal insulin, the Lantus, which lasted 24 hours, 22 to 24 hours, matches the physiology of the Decadron.
Sure. Yeah. So Dr. Ramsey was saying, depending on the steroid, because of the half-life, it will affect the blood sugar in different ways. Overall, the postprandial blood sugar will always be hyper elevated because of the steroid. So you may have to increase the basal, but because of the physiology, the postprandial insulin will help you with steroid-induced hyperglycemia. Okay. Here we go. So, of course, we talked about the insulin right on the floor, and then of course there's insulin drips. And so it's good to know what are some of the conditions to use the insulin drip. So septic shock, not necessarily to treat the sepsis and the underlying cause there, but because the patient is so acutely ill and reactive that their blood sugar can be so labile. So it is appropriate to have them on insulin drip, and you've probably seen that in your ICU rotation as well. Of course, right, one of the main diagnoses is DKA and HHS, hyperosmolar hyperglycemic state. And then you'll see this in the CVICU. Same concept for the septic shock patients, the post-CABG patients. You'll walk in the room and they may be on dobutamine, but they may also be on the insulin drip. And that's to CT surgery has their own studies that have shown improvement in recovery and outcomes by keeping a lower range for blood sugar for their patients. So that's why they do that as well. We'll look at quickly how to order because you probably will. We can do the Glucomander on the floor in PCU, so you may actually be putting it in even if you're not on an ICU rotation. And the title of that order is Glucomander DKA. I just type in DKA and the order pops up. The good thing is it's a whole protocol, and most of it is pre-selected. There's just a couple of things we need to go through and decide if you want to order them, like labs and fluids and different communication orders, but we'll talk about that. So this is from the ADA, and I get this question in rounds. I'm sure we all can relate. What are some of the differences between DKA and HHS, right? Because they can present similar, the treatment is similar, but it is important to know the difference. Okay, so like I said, this is from the ADA, and these are just kind of typical patterns, right? So for DKA, typically, and I say typically because if you have high insulin resistance and uncontrolled type 2, you can form a type 1 physiology of diabetes. Okay, so that's why I say typical. So typically type 1 is DKA. Glucose is in that range. And I say usual because this is not a concrete, stamp on this. The ADA knows that each patient may be slightly different. You may have 5 of these criteria and 1 of that, and you really need to decide, is this most likely DKA or HHS? The guidelines used to be, you need 3 of this or you need 4 of this criteria to say, and now it's changed. It's more of, look at the patient, look at the data, where are we leaning? Okay. So pH, of course, right? This is acidosis for DKA, so less than 7.3. Serum bicarb is going to be low. That's in the same picture. Serum ketones going to be elevated. And then serum osmolality may be normal or mildly elevated in DKA. And then, of course, the classical, right, is the elevated anion gap above 12. So that's kind of broad objective data for DKA. HHS, typically type 2, blood sugar is very high, 600 or greater. The pH, you're not going to have that overall systemic acidosis like DKA. And then why do they say bicarb greater than 15? You would think maybe it should be greater than 18. Well, because there may be lactic acid in HHS. You're dehydrated, you're still having, nausea, vomiting, diarrhea. And a lot of patients have lactic acid from hypoperfusion. So their bicarb may in fact not be, completely normal. Okay, so then this goes back to look at the whole picture, look at these numbers, and really decide what is this? Is this realistically DKA or HHS? And then, of course, for HHS, you're going to have an increased serum osmolality, and then your anion gap should be, normal. Okay.
I just add, I think the main thing is the serum ketones. That really helps differentiate the 2 of them. Because there can be a lot of overlap, but if you have high serum ketones, it's pretty much DKA, and if it's absent or mild, it's HHS. That's the main thing.
I'm glad you brought that up, because one thing is, we all know from med school what beta hydroxybutyrate is, right? So they used to test that a lot, and you can still test that. It's the most specific marker for lactic acid in our body, but you don't need it. If you have ketones in the urine, then that's okay, but you'll see it ordered most of the time in the ER anyway. Okay. Oh, yeah, this is just to be complete. I was saying if you're going to put in the insulin drip, oh yeah, I heard it. So you just type in DKA, that's what I do. So it's common sense. So Blue Commander, that's the first order there. It will be a whole order set. A lot of things will be selected here. But really, this is just the insulin part. So it will preset 1 unit per milliliter. That's okay. You can keep it like that. That's the FDA approved first rate for the insulin drip. All right. And like I said, if you haven't done this yet and you need to do it, sit down and do it with your senior or attending. But a lot of it, thankfully, is self-explanatory when you go through the order. Okay. So, what I started with is we do this because this is evidence-based medicine. We're giving the best outcomes to our patients by giving them a range that is appropriate, that's proven to help them, but just mentally to show that you're working hard to the hospital system that you're involved in. Be aware, the blood sugar is above 300, it's already abnormal. We really need to bring that in and control that. So if you're chart checking in the morning and you're looking at your patient and overnight it was 4 something, and make sure you have a solid plan, talk to your senior that's a patient that we need to have a microscope on for their blood sugar that day, okay? And then of course, even more dangerous is the hypoglycemia, okay? We talked about stopping oral agents. The caveat is, with the 4 pillars of heart failure, we're doing the SGLT2 inhibitors. So you can continue their oral SGLT2 inhibitor for heart failure. Okay, so still hold it if it's for CKD, still hold it for if it's for diabetes. Okay, and that's not just an Advent Health policy, that actually is part of the ADA guidelines for 2026. Okay, all right, and then we talked about the TDD, the total daily dose. Okay, know what that number is. We were just in rounds the other day, and we had a patient where we knew their A1C, we knew how much insulin they were on at home, and we're still increasing the insulin every day. They're still getting 10 units in 24 hours on the correctional scale. I said, let's take a step back. Let's calculate the total daily dose. Let's see if we're even in the ballpark of what we're doing. And in fact, the total daily dose was way higher than what we were doing. So it's good to know, to give you a reality check of, am I, what I'm doing even coming close to what the patient needs? Okay, we talked about steroid-induced hyperglycemia, being proactive and not reactive, understanding what steroid is being given for our patients. And don't depend on the sliding scale. No. And then, yeah, lastly, like I said earlier, if patients do get concerned if they're on insulin, they think it's for no reason, let them know this is why you're in the hospital. Okay. All right. Oh, of course, we got to do questions. Okay. Just two questions. Let's get the intern to read one of these. These are no trick questions. They're straightforward. Who wants to read it? Okay.
67-year-old man is evaluated in the hospital for hyperglycemia 3 days after admission for a COPD exacerbation. Appropriate treatment was initiated with antibiotics, bronchodilator, supplemental oxygen, and systemic glucocorticoids. The patient's oral intake remains good. Since the initiation of systemic glucocorticoids, fasting blood glucose levels have been consistently greater than 180 milligrams per deciliter, and postprandial levels occasionally greater than 250 milligrams per deciliter. On admission, A1C was 5.3. Which of the following is the most appropriate management of these patients' hyperglycemia?
Fine. So the question's telling us, actually, Dr. KB is bringing this up, right? This patient really doesn't have diabetes, but we're definitely dealing with hyperglycemia, and we want the patient to be in this range for safety, for outcomes, right? So it's telling us not only the postprandial blood sugar is high, it's also telling us just the basal, or just the fasting insulin is high too. So what is that kind of light bulb in your brain? What kind of insulin should we at least be using and managing? The basal.
Prandial.
Okay, and are we sure that is going to be enough, or what do we typically do to help us fill in the gap?
Yeah, the current.
Is the correctional, right? Like I said, this is not a trick question, but this is a good example of giving a patient insulin when in fact they may not have diabetes. Okay,
Just add a quick comment to the question. Whenever they tell you the patient is eating, pick an answer that has prandial. And never pick correctional alone or basal alone. You need both to not have the peaks. You need both for more sustained control.
absolutely, yeah. Okay. Last one, a little more involved, but still straightforward. Okay, who else wants to read this one? Okay.
66-year-old woman was admitted to hospital 24 hours ago with a community-acquired pneumonia. Since admission, she was being confused and her oral intake has been poor. Further antibiotics, intravenous fluids, and oxygen have been initiated. She has no other known medical problems. Physical examination, temperature is 39. Blood pressure is 142/88. Pulse rate is 98. Respiratory rate is 20. Oxygen saturation is 90% of oxygen, 2 liters. Particles are evident in the right posterior thorax. Laboratory studies show glucose values of 185 to 250 and a hemoglobin level, A1C level of 5.5%. Chest radiograph demonstrates a right to lower lobe infiltrate. Which of the following is the most appropriate management of this patient's hyperglycemia?
So we have community-acquired pneumonia going on here. Obviously, this is a diabetic question. This is another case patient, technically doesn't have diabetes, but they're not in goal. And some important things in this question, Dr. Francis mentioned in the last question, they're already giving you a hint about their trajectory with how much they're going to eat, if they're not going to eat. So, for all purposes, to me, when I read a test question like this, they're NPM, right? So count on them not really eating. And then, so if they're not really eating, then we need to hold off on a postprandial, insulin, because that's going to cause hyperglycemia. but they're still not at goal. They're still, they still have hyperglycemia. So this kind of goes back to the fact earlier of, even if you're MPO in the hospital and you're not within goal, doesn't mean you have no insulin. You should still be on basal insulin plus the sliding scale. And if you know, this question doesn't have this, but if you know the patient's home basal insulin, then the recommendations are to at least half it with the correctional scale, all right? And then once they get cleared for a procedure or whatever, and they start eating, then don't forget, you do need to look at their regimen for mealtime and add that, okay? And then, of course, put them on their regular home basal regimen. Okay, so just two questions to give you different scenarios, all right? I get, and for the first question, or the first option, we know why that's not enough. For B, we don't want to resume their oral diabetic med. And then the last is we already know it's ready. Okay. That is it. All right. I know we did some questions, but yeah, we can open them.
If a patient's med surge, endocrine society is leaning back towards getting patients back on their oral diabetes medications. I don't want you to think of that as like a hard fast rule. For now, hold all their home PO diabetes except Jardiance and heart failure, obviously, if it's not contraindicated. But I think we're going to see a shift in the coming years of like letting people that are here just for like surgery or something stay on their metformin and whatnot. I don't know if you read anything about that. But
Yeah,
it's better to check that someone, you maybe switch them back to their home regimen before they are discharged to make sure their blood sugar is not going to spike up.
Yeah. Yeah, the advent goes up to ADA. And every year the ADA prints out probably 20-something pages of what their diabetic recommendations are. Most of it is outpatient, so I'm glad this is a lot easier to talk about. But that's what advent uses, so and that's why. But you're right, there's a lot of other societies we may see,
Yeah, us, the American Hospital, Society of Hospital Medicine, geez. They kind of recommend the same thing, that low risk patients who have good glucose control, you can continue with the oral regimen so long as there's no absolute contraindication to doing so.
Thank you for a really excellent lecture because it was really good from the baseline up. I wanted to ask the group a couple of more questions, just for fun and for making sure that you really got everything. So interns should answer. It is 11 o'clock or 12 noon, so lunchtime. The nurse calls you and says, the patient is due to have 15 units of this pro right now. The sugar is 120. Shall I give it? What are the questions you have to ask? And what is your answer? So what?
Have they already eaten?
Loud and clear.
Have they already eaten?
Are they eating? Number one. Okay. So the nurse says, I'm not really sure, they haven't really started yet, but the patient is a bit nauseated. What are you doing now? I mean, they need an answer from you. Shall I give the 15 units, yes or no?
No.
Right, no is correct, but there's a but. Because if you go for no, the patient will not receive 15 units of insulin and will not receive, I mean, anyway, no correction, but will not receive the units. But the patient says, yeah, I'm nauseated, but then the patient starts eating a bit. Okay, so what do you have to do? You have to call back later or say to the nurse, you know what? Give me a call back in another half an hour and let me know if the patient was eating. And then you ask, did the patient eat everything? 15 units. Did the patient eat half of it? And perhaps half of the units, perhaps instead of 15, you get 7 or so, And if they say, oh, they just had a few bites, you can just say, just give what is correction on there, or give just a couple of units or not at all. Okay. Second question is, they call you in the evening. you know. Same scenario, the patient is in the bed, has a sugar of 110, and the patient is scheduled, it is 8 p.m., and the patient is scheduled for a long-acting insulin, 20 units or 30 units. And they call you and say, look, the patient is in the bed, and I have you in order to give 20, 30, whatever units of Lantus, okay? But the sugar at 6 p.m. was 110 or 120. Shall I give the insulin? And you need to answer yay, nay, or what? So what would you like? Do you want to know anything from the nurse, or is it enough information? Or
pure midnight.
louder?
I think pure midnight. If they're in pure midnight, you have to give half of the base of.
So Lantus is something which you always should give. You have learned that already, you know, as for the diabetics. But Lantus always should be given, should not be hold, in principle. In principle, okay? So if you say, I want to give the insulin, the only thing you have to check now is the patient scheduled for surgery perhaps tomorrow? Okay, perhaps just like that, because if the patient is scheduled for surgery and has at nighttime already really nice, well-controlled sugar, perhaps under these circumstances, you want to go instead of 30, you want to give 20 units, because they will be fasting for the longer period of time. They never go at 6 a.m. for surgery. You know, it might be 11 o'clock, 12 o'clock. But if they're not fasted, then you have a good controlled sugar, and that is exactly what they should do, you know. And the other thing is about IV insulin and subcutaneous insulin. How quickly is IV out of your system, Justin?
IV out of the system?
Yeah.
I
give you 10 units right now. How long is it in your system?
have no idea.
Minutes. Therefore, we always say, if you are in DKA, do not stop the drip before you have given already a couple of hours beforehand subcutaneous. Because you stop the drip 2 hours beforehand subcutaneous. You stop the drip and literally, I mean, perhaps not immediately, but say 10 minutes or 15 minutes later, you know, the insulin is gone. The subcutaneous, on the other hand, you know, you have seen this great table with how long does it take to get in and how long does it take, the half-life time and you just need to know these things, right? If you have a patient who is a resident, the resident is your patient, is an type 2 diabetic, you know, and tells you, oh God, I can't stick to my insulin regimen. I'm on call and I'm running and I'm busy here and busy there. Sometimes I eat at 11 o'clock, sometimes I eat at 2 o'clock, sometimes I don't have lunch at all. What instructions do you give to such a busy person who cannot calculate at all the demands of the insulin? And what insulin do you preferably give to them?
Okay.
What? So you have somebody who healthy, you know, potentially is not eating at all and is supposed to take the insulin, or is eating in a few hours. If you give instructions, the moment you start eating, when you sit down to eat, you take your very short-acting insulin. That is the right instruction. Don't go breakfast, lunch, dinner at a certain time, because the word prandial means eating, food. So the very short acting goes in 5 minutes. So when you start eating, before the sugar goes up, you pretty much first bite, first shot. You know, that's the best way of regulating these kind of things, you know. And then the other thing about the one table which you gave about 0.3, 0.4, 0.5, 0.6 multiplier by the kilograms. I just wanted to say, if somebody's insulin naive, be a bit more cautious with the calculation. Even if they are, as we said, obese, you don't know how they're responding. An insulin-resistant patient, you give 1 unit of insulin subcutaneous, they might not even respond to this 1 unit. An insulin-naive patient, perhaps, yes, already starved for a while, might go immediately down by 30, 40 units of the sugar, okay? There's a big discrepancy of how people are responding to insulin. So if in doubt, you always go a bit more careful, but you put the correction scale on, because then the nurse is correcting your mistake. And you said it perfectly. The next morning, you go back. You look how many units of total insulin were given, and then you have to calculate, you have to give the Lantus, or do you have to give perhaps only a few more units at lunchtime because only the lunch sugars were high, whatever, all right? And very important, so as a summary to say when you're on call, don't just handle these kind of on calls with just the sugar. Ask, are they eating? Are they nauseated? Are they going for surgery? Or if you cannot figure anything out, tell me the sugars in the last 24 hours, because they will tell you a lot about how the patient is, Some people are so unstable that it is better to have them running at 220 than shooting them down. But that is then a fine tuning. You can talk to your team about it. Very excellent lecture. Thank you.
Yes.
Yeah.
Yeah.
Sorry to
No,
throw in
no.
one more little pearl,
Yeah.
but thank you for the lecture. Sorry, not for me. The reference for the sliding scale and moving away from that and moving towards more prandial correction is the Rabbit 2 trial by Gutierrez. He's like one of the top endocrinologists from Emory. So that can give you like a foundation of what Dr. Vernace was talking about.
Right, and since we're talking about trials, the original trials for diabetes control, I've forgotten what's called sugar trial or whatever, 20 years ago, were saying you must control diabetes very tightly to have a good outcome. And you're aiming for a hemoglobin A1C of less than 7. That is totally wrong. Nobody needs a tight control. You will never get a patient tightly controlled, and you're doing more harm than you do any good benefit. And a hemoglobin A1C of 7 might be nice for a young active person or so, well controlled, but you're aiming the older and the more comorbidities they have for A1C between 7 to 8. That is a safe range.
Yeah, there's that rule. You can, I think after 70 years old, you can add a point to their A1C. So if they're 80,
Yeah.
A1C of 8 is fine. 35, A1C of 8.5
Yeah.
fine. 90, well, they're
Right.
pretty good.
But in this population, you're doing significant more harm with the tight controlled sugar than with the high sugar. The high sugar takes 10 to 20 years to give you a problem. By then they are dead.
The American College of Physicians actually recommends,
Yeah.
for everyone's point,
Yeah.
that 7 to 8 is a good target
Yeah.
for our older patients. Dr. Vernace, very good. I wanted to ask you, do you guys have a hypoglycemic protocol?
Yeah.
Every time you order insulin, it'll auto-populate that.
They are. Okay.
And it's pretty good. It walks the staff through. By the time we get paged, usually it's to tell us that there was a low reading, they did X, Y, and Z, and now it's fine.
Right. And you realize when you give sugar, then they quickly come up, give the highest amount, whatever you can find. Orange is pretty good. But that has to be followed always by protein. Because if the sugar goes high and you give the orange juice and then the sugar goes high, the body will counteract the high sugar with more insulin. Okay. So you have for a moment the good side effect to increase the sugar, but then the protein has to counteract the more insulin production. Right? Never forget that.
One.
Sorry, Mike, can I
Yeah,
add one thing?
and then Dahlia.
Yeah, sorry. No, this is just like anecdotal. This has happened to me before where I've had a patient who's had sugars like 200s, 300s, and we're treating with insulin and everything. But I think sometimes we forget to like go in the patient's room and see what they're actually eating because they always have family members who are bringing in cookies, chocolates.
Got guys down
Sorry.
here. A nurse texted me this week,
Yes.
a picture of the patient's Uber Eats order. It had, this is the patient, 341, the blood sugar that was 400 at night. Snickers bar with, Twinkies, Starburst, the whole bag with ramen. The whole bag was full of candy, a Publix bag. So, you can't counteract that. There's no amount of insulin that you want to give for that.
And also remember that the carb control diet contains pancakes. So like, I mean,
Yeah, that's
yeah,
what.
you walk in and be like, why are your sugars 280? It's because, breakfast every morning they're getting pancakes and then they're ordering out for dinner and it's, yeah, so really gotta like
And what
teach them.
start considering you 500?
That's a good question. For us, pretty much never.
Repeat the number.
So, yeah, for us and online, when do we consider using U500, which is ultra concentrated insulin? And I've only seen it being used maybe 4 or 5 times in practice and in residency. But it's patients typically with incredibly poor type 2 diabetes, extreme insulin resistance, and just because of price and volume, you can't be on 200, 300 units of insulin a day. And so they have U500. If you have a patient like that, it really is an automatic pharmacy consultation. Let your attending know, consult pharmacy to dose that because it's extremely potent. And believe it or not, there's some sad adverse events that happen with that because of miscommunication. You give U500, their normal dose, all of a sudden they got, 10 times their insulin. So good question, but 99% of the time you won't use it. But if you
That is
do,
not in order for you to give. And in the outpatient scenario, such a patient, this was an endocrinologist, not with you,
We had it last week. I think that's why Odali's asking about it.
right?
mhm,
We had it in 500.
and pharmacy
They like.
was on board, yeah.
Perfect, yeah, because it's not for you to do
Mhm.
this.
Yeah,
I was
it,
just wondering how the calculation would work.
yeah, well-
Nobody knows.
Nobody's.
It's very difficult to calculate because with obesity, the distribution of the insulin is very
Yeah, okay.
different than with a normal person in the room, it's like, let pharmacy do it.
And
Yeah.
it's not on your board, so anything that's not on the boards, I don't know where you post it.
But
Very rarely, if you do end up, it's usually a home medication that they're on, and the patient will even tell you, like, you will try everything insulin wise on me, and it will not work. You need to put me back on my home U500.
The last